All right, this is going to be kind of a schematic approach to trocar placement for the XI robot. Got your classic bariatric abdomen here. For me, the first move before I mark or inject local anesthetic is to insufflate the abdomen. I like to use a Varus needle on the left costal margin. And I like to insufflate because I like to determine what's going to be the apex of the abdomen. And what I mean by the apex, of course, is with the patient in a supine position, viewed transversely, with the abdomen insufflated, there's typically going to be a highest point that's somewhere at or above the level of the umbilicus. And we want to see what this point is because this will help us a lot with trocar placement. The XI generally likes to be relatively far away from the action. XI arms are very long, so there's not a problem with reach. And yet you don't want to be far below the apex because then you start getting below the action and lose your perspective. And so typically with a gastric bypass, if the apex is hereabouts, then I'll be on the apex or 1 or 2 centimeters caudad to it. Again, not getting too far down because I don't want to lose the downward look that I want on the action. If it's a sleeve, it's going to be essentially the same trocar placement, except that it'll be on that apex or perhaps slightly above the apex line, maybe 1 centimeter cephalad to the transversely oriented apex. So let's say I've chosen this line as my apex transversely. And so I'm going to start with placing my camera trocar. This is going to be XI port number 2, just to the left of the midline. We place it just to the left so as to avoid the falciform ligament. This is still going to have a decent perspective from the jejunal anastomosis that we'll create for our gastric bypass. I'll go from this as my focal or anchor point to the second trocar placement about 8 centimeters away, and then another 8 centimeters away. And then I'll come over and work on port number 1, which I'm going to place about 10 centimeters away from this anchoring point and now above my transverse line of orientation. I'm going to put it above because that leaves room for my assist port down in this area. And now this gives me a nice arm angle. So these are the robot arms. It's focused on, let's say, the jejunal anastomosis. And because I've brought this port number 1 up just a little bit off of the transverse line, I've got a nice opening angle here in this space. It's going to leave room for my assisting surgeon. So the assisting surgeon and their instrumentation are going to be between port number 1 and the camera. In my setup, this works well when we're talking about the mid-left abdominal area of interest or the upper abdominal area of interest. Of course, that would be forming the gastric pouch or hiatal hernia or something along those lines. Once again, bringing that port up a little bit gives me sort of an angle spread that allows the assistant to have some comfortable working space. This, in summary, is the gastric bypass setup. So this is a 15 port at site number 1. This is the robotic left hand, the assisting hand. Sometimes that's a Cartier, sometimes that's a needle driver, and certainly when I use a stapler, this is the location for the stapler, and I'm using all the staples for the entire case through this port number 1. The assist, as I mentioned, this is a 12 millimeter port. It needs to be a larger port because the assist is going to be passing sutures in and out of the abdomen. Number 2 is the camera throughout. In my technique, I don't do any camera port hopping, although that certainly is an option for your XI technique. XI port number 3 is an 8 millimeter port once again. That's my right hand. That's where the dissection and the suturing are happening. And then port number 4 is for retraction. Very similar setup for the gastric sleeve in my cases. Again, this whole line of trocars might be just slightly higher, but is otherwise oriented the same relative to each other. The assist port is a 5 millimeter, and you could make a case for not even having an assist 5 millimeter port, but I find it's useful to let the assist be in there to retract or to suction or apply cautery at certain points during the case. The 5 millimeter port does not seem to bother the patient, so this is a part of my routine setup. Only difference being, of course, this is still port number 1 is the stapler, number 2 is the camera, number 3 is going to be mainly vessel sealer, and I also do some suturing with my sleeve technique and retraction here at number 4. We haven't talked about the liver attractor. At our hospital, we use a Nathanson liver attractor, so this is meant to signify the external portion of the retractor, which is sticking out upwards and somewhat to the patient's right. When we bring the XI port in to dock, what we're going to do is rotate the arms so that the external arms are split, with number 1 and 2 being well towards the patient's right, number 3 and 4 being well towards the patient's left, and then the next slide will show how the internal arms are oriented with those, again, looking at the jejunal area of interest. Assist hand, camera, surgeon right hand, and then tissue retraction. So that's pretty much the schematic approach to robot trocar placement using the XI robot, primarily gastric bypass, but also sleeve.